All right, so I'm going to talk a bit about some work we've been doing in improving risk calculation for atherosclerotic cardiovascular disease with machine learning techniques. Real quick, I want to give a shout out to our collaborators. They're not here today to present with me, but this is work that we've been doing with Dr. Mac Ruffin and Dr. Bill Curry. And their medical expertise is invaluable because I don't have any. So although I can talk a bit about the computational work, I will have difficulty fielding questions about particular interpretations of any medical findings here. Okay, so atherosclerosis, as I'm sure you know, is a progressive cardiovascular disease that affects a huge swath of the population. It's estimated to be an underlying cause in about half of all deaths in developed countries. And it's kind of clear why that is, right? It is a contributing factor to a wide range of acute cardiovascular events, stuff like stroke, heart attack, heart failure, kidney failure. So this is the sort of disease where if we can have accurate risk assessment, especially accurate early risk assessment, it has the potential to impact a very large population, and not just by recommending like medical intervention. This is a disease where a lot of the risk factors are things that can be influenced. So, sorry. So this is the sort of thing where if we can improve risk calculation here, we could really have a very large downstream impact on patients. So you're probably familiar with something that looks like this. This is a heart risk calculator that you can find on the internet or on apps and things like that. And risk calculators are commonly used because they're very simple in terms of access to both the information you need and the ability to use them quickly in a clinical setting. Right? So you have some simple little interface, you can plug in a small number of details and you can immediately calculate a risk score based on the patient characteristics that you have right here. Usually you want these to be very easily accessible measurements from a patient. And you want to be able to do it quickly in the clinical setting, right? That's the goal. So sitting on the back end behind this little interface is some kind of cost proportional hazard model. In this case, this is the risk calculator that was developed in 2013 by a work group from the American Heart Association and the American College of Cardiology. But the basic direction of this work is, well, imagine we have this same risk calculator, right? Interface looks exactly the same, use case is exactly the same, but in the back end, there's actually some kind of machine learning algorithm, and can give us more accurate or more useful risk assessments for patients. And that's the question. That's the sort of thing that, if it's true, then we can implement it into clinical practice relatively easily, right? This is an interface people are already familiar with. So the kind of baseline comparison here is this 2013 risk calculator that was developed, a very large study conducted by a work group for the American College of Cardiology and the AHA. And the risk calculator is focused on 10-year hazard for ASCVD events based on risk factors that are already well known. And they had a list of biomarkers they were interested in further study about, right? Whether or not they could be useful in including. So the conditions to be included in this study are that the patients had to be between the ages of 40 and 79. They had to be apparently healthy with no history of any of these adverse events. And they had this critical question one here at the bottom: what is the evidence with regard to reclassification or contribution of risk assessment of all these other biomarkers? These are biomarkers they were interested in, but which had not been used previously in calculators like the Framingham risk score or what have you. So a lot of their conclusions are actually highly uncertain. So they do reach some conclusions for some of these variables, for family history, and others. They say that if the risk calculation is uncertain, then a clinician can consider some of these. They recommend against measuring the carotid intima media thickness. And then for several other of the biomarkers they're interested in, they really reach no conclusion at all. So our research question is, in the first case, can a machine learning model better predict this risk using similar variables that are used in this risk calculator? Right? So if we just have the same interface, can we do better? And number two, can we identify some of the biomarkers that they were interested in, but which weren't included, and can these actually improve our prediction? So in other words, can we help answer critical question 1 for some of these biomarkers that they didn't reach any strong conclusions about? So a quick comment on why use machine learning. And this was kind of brought up in Justin's presentation. If logistic regression sometimes does just as well, what's the point of machine learning? Well, as Dr. Hanauer says, it really depends on the data set and the experimental condition. But one thing to keep in mind about linear models, like a Cox proportional hazard model or a logistic regression, is that they make really strong assumptions about the relationship between the stuff that you measure and the outcome you're interested in. In particular, when we call a model linear, what we mean is that for any of the variables we're interested in, say like age is a measurement we use to predict it, we make this assumption that any increment in age is going to have always some proportional effect on the outcome. What that means is aging 5 years in your 20s is going to increase your risk or decrease your risk the same way that aging 5 years in your 50s would. And we have pretty good reason to think that that's probably not true, right? The effects of aging, in particular, it seems reasonable to think it's at least possible that aging accelerates, right? That your risk starts to increase faster as you get older. It's not the same across like teenagers and people in their 60s. The machine learning models allow us to relax those kinds of assumptions with nonlinear relationships, and they don't require us to do this using our own prior knowledge necessarily. We can pull it from the data with big enough data sets. So like, it's very common in a linear model to include something like an interaction term, right? You can say, well, age interacts with systolic blood pressure, something like that. But these are interactions that you either include in the model a priori, or you try to include a huge number of higher order interactions and then select the best ones. That gets infeasible relatively quickly. So there is a trade-off though, which is that machine learning models are harder to interpret, right? Because we have weak assumptions about what the actual relationship between the variables and the outcome is. It's no longer easy to just read off of the model what the effect of some variable is, right? If you have a linear model, you can just say, this is the effect of age in the prediction. It's always some coefficient associated with risk. Not super easy to do that with machine learning. Okay, so here are the variables. They're actually included in the model, and then outcomes, and also things that they were interested in but excluded for various reasons, right? So the left-hand column here is the variables that they include to make their prediction, and their outcomes are defined as death from chronic heart disease, a non-fatal heart attack, or stroke. Those are the only outcomes they consider. In particular, they do not actually define as an outcome heart failure. They were interested in this, but they concluded that they were having problems across cohorts with the consistent diagnosis of heart failure. And similarly with coronary revascularization, because this is a procedure, this was influenced, they felt, too much by the actual judgments of particular doctors at different hospitals. And so their data comes from many different sites, but all of it comes from past RCTs. So, well, in the right here, in the variables they're interested in but they excluded, all the ones you see in bold here are things they ultimately excluded because they felt they didn't have enough data. So this is something where access to large retrospective cohort could really help us out. And then the bottom table here, you see a little breakdown of the event rate for different demographics, race and sex. So we evaluate this on some TriNetX data using the research network. And we have a cohort that we've pulled from there of about 8 million patients that were selected for studying a broad range of chronic diseases. And from this, we construct cohorts specifically to try and match as best as possible the conditions of the ACC and the AHA study. So we have two cohorts here that we use. The first is, well, both are patients in 2009, between the same ages that are used in their study, and for whom all of the relevant measurements are available with no history of cardiovascular disease. When I say the relevant measurements, I mean the measurements necessary to completely calculate the AHA risk score. So we don't exclude patients just because they don't have measurements on some of the other variables we're interested in, as long as we can calculate the work group's risk calculator. And the point of that is that we want, as best as possible, to do an apples to apples comparison, because missing rates for data can be very, very high in EHR. We don't want whatever method we use to impute or to handle missing data to affect the assessment of the quality predictions from the work group's risk calculator, right? That's supposed to be our baseline that we want to beat. So we don't want our choices to affect the quality of that, right? We don't want our way of handling missing data to affect that. Okay, so that's the first cohort. The second cohort is a sub-cohort that is either alive after 10 years or has had an ASCVD event. In other words, we exclude everybody who died before they had a recorded event. And the goal here is just to exclude confounding with different outcomes, right? So in the first cohort, lots of patients might end up not having an event because they died of some other disease, right? And we include that 7 of the other variables that they were interested in. And variables that are missing are coded using indicator variables. Okay, so here we have a little sanity check looking at some cohort statistics. So we define a couple outcomes on top of the cohorts themselves. And one of the difficulties in defining outcomes is that we don't actually have access to the cause of death information, which was used as an endpoint in the AHA study as one of the endpoints, right? So death due to chronic heart disease. So what we have instead is heart attack, stroke, cardiac arrest, and heart failure, right? We have diagnostic codes for these. I break this down into 2 different outcomes, right? We're going to assess this on 2 different prediction tasks. The reason they very consciously excluded heart failure. So us including it, obviously, is a little bit of an apples to oranges comparison. So we want to at least consider the case where we're not predicting heart failure at all, as they originally designed it. Number 2 is the missing rates here for the biomarkers. And you'll see that almost all of these are over 90%, and all of them are over 80%. So, whoops. There we go. So yeah, missing is a big factor in EHR data. And the way that this is handled is we have a variable in the model that indicates whether or not this measurement has taken place. This is a standard way of handling it, especially in linear models. But there are more sophisticated methods that we can use, but at the very least, this does not require us to make the kind of assumptions we would need if we were to impute the missing data, right? Imputing the missing data here, I think, would be a mistake. The big reason is that the missing rate is so high on these variables that if you do something like look at the average across the population of people who were measured for something like even BMI here, you're looking at the average of about 10% of people, and then assuming that holds across the 90% who weren't observed. And there's probably good reason to believe that that's going to be biased by the reason that this data was recorded in the first place, the reason that a doctor measured this. So we avoid imputing that data. And the sanity check here for our outcome definitions, we can see the actual percent, which hovers between, for our first outcome, between 11 and 14%. And that is in the ballpark of the outcome percentage in the RCT cohorts that the AHA had defined. So they averaged around, across the whole cohort, 12.5%. So we're in the same ballpark. Now that's a very crude way to just check that we're not heavily biased in some way. And it doesn't guarantee that we've eliminated that kind of bias, but it is a quick check. Okay, so what does our experimental setup look like? So we look at a couple different models compared to the AHA risk calculator. The first is lasso regression. This is a linear model like the AHA risk calculator, but it includes a penalization term. And you can think of this effectively as a kind of linear model that when you fit it, it also does variable selection at the same time. So a common use case for this is in things like genetic studies or studies where you have huge amounts of data. You can reduce down the number of variables you're actually going to look at the same time that you fit the model. You don't have to fit a bunch of models and do some kind of variable selection technique by evaluating a bunch of different models that you fit. And then we're comparing to two ensemble methods, the random forest and gradient boosted trees. Both of these are a collection of nonlinear models that you can think of as voting on the outcome. So we'll have a bunch of different predictors. Each one of these little models will make a prediction based on some small number of variables that it's allowed to look at, and then they all get together and are aggregated to produce an outcome or a prediction of the outcome. And the AHA risk calculator, as I mentioned before, this is a proportional hazard model. It's a linear model. It includes a couple interaction terms in it, but it is, you can think of it as basically in the same model class as the lasso regression, although it's fit in a different way. I mentioned before, our missing data is represented with indicator variables because we don't want to impute the data in this case. And we're evaluating them using the average AUC and 5-fold cross-validation. So let's take a look at this table here. So there's a lot of numbers here. Let me kind of break down what you're looking at for a moment. So here, each column is the performance of the models on a particular outcome in a particular cohort. Each row is a particular model and how it performed. And each horizontal block here, the three feature sets, are different independent variables that we use. And in particular, if you look at the blue highlighted row marked AHA, this is the work group's risk calculator. So those four numbers there are how it performed on the different cohorts on the different outcome definitions. And those are AUC scores, as mentioned before. Everything in the middle block here are the two ensemble models and the lasso model evaluated using exactly the same variables that are used in the AHA work group's risk calculator. So this is, don't have access to any additional information. Do they perform better? And one thing we see right away is that actually this lasso model, which is itself a linear model, is often the best when we're restricted to this amount of information. It's worth noting that the AHA model is never the best on any of them, even within this block. We don't want to draw too hasty conclusions from that, but it's at least indicative that there's room for performance, at least on outcomes as we've defined them. Another thing to look at here is these other two feature set blocks, right? So feature set 1 and feature set 3. Here we're looking at how models perform when we include information that isn't used in the AHA calculator. And right away, we'll notice that in every case, the numbers go up, which is good. So I didn't explain AUC, but this is a score from 0 to 1. 1 is perfectly calibrated and accurate. 0 is the worst. 0.5 is about how well you do with random classification, right? Random risk assignment. So we see that each of the models, right, not just the 2 ensemble methods, but even the linear model, does better when we include more information. Another thing worth observing is that the best model across all the feature sets and across all of the conditions is actually this ensemble method right at the bottom. This performs best, not just in this block, but actually, if you look at each column, this is always the best. So the more information we include, the better these machine learning techniques do in comparison to the original AHA score here. Now, there's one other slightly interesting thing, which I don't want to speculate too much exactly about why this is, but it's something we need to notice, is that, so outcome 1 was defined as excluding heart failure, and outcome 2 was defined as including heart failure. And outcome 2 is therefore including outcomes that the AHA consciously ignored, right? However, when we assess the accuracy, the AUC of the AHA model, it actually improves on outcome 2. Now that's counterintuitive, right? We would expect that if we're including an outcome they didn't include, that their model would perform worse because it wasn't actually fit to that data. So I don't want to speculate too much on this, but one possibility is that because we don't have cause of death information and we're kind of using cardiac arrest as a proxy for that, including heart failure, the diagnostic code, might actually bring in a lot of patients who die of cardiovascular disease that would be coded that way in the AHA study. And that might account for why the work group's risk calculator improves under that condition. That's a speculation, but this is just a curious phenomenon that I wanted to note. So we see that the machine learning model, the ensemble method, is doing better when we have this maximal number of features, right? Feature set 3 with all the interactions. But we also see the linear model with the variable selection is improving over the AHA model. So it's worth asking, what exactly is it including? Right? When we look at feature set 1, outcome 1, right? This linear model is significantly better than the AHA risk calculator, and it's using variables that aren't included. So what are they? So here are the variables used over and above the risk score assigned by the AHA calculator. And the ones in bold are variables that aren't used at all. And these are ordered in descending order of effect size, where by effect, I mean effect on the prediction outcome. We're not estimating causal effects. And the very first one is family history of heart disease, which is not terribly surprising, but it is somewhat surprising that it's not actually included in the AHA risk calculator in the first place. So this seems to be a little bit of a no-brainer, but it's also worth noting that 2 of the variables that it includes are things that are excluded by the AHA and that they reach no particular conclusions about. So what are the takeaways here? Well, our first research question of whether we can actually improve risk calculation using machine learning just restricted to the variables that the AHA and ACC use. Well, the linear model does best when we're restricted there. The GBT model outperforms the risk calculator in all the experimental conditions when we use as much of the available information as we can. And the second research question of whether we can identify biomarkers that are not included, and can we help answer the critical question 1? We can give maybe a tentative yes here, right? So all of the models perform better when we include these variables that they're not using. And in particular, even the linear model does better when we include variables that they don't reach strong conclusions about, or that just aren't included in their models. Okay, so the future directions of this work, this is ongoing and there's a lot yet to do. One of the biggest areas going forward is accounting for longitudinal effects or longitudinal factors. In this initial study, we've just looked at patients in the year 2009, data that was recorded then, and we predict a single point in time in the future. But realistically, we have lots of data about patient histories. And by excluding that data, we're actually excluding a lot of potential information that we could use to make predictions going forward. So there are longitudinal representation techniques that we could use either to plug in to existing models as features, or to use models that directly use longitudinal features. Right? The second is a second critical question that the work group was interested in, which is, can we assess long-term risk using some of these variables? So long-term risk, which they define as over 15 years or lifetime risk. And the reason they're interested in long-term risk is that at present, you basically only assess people in general after the age of 40, right? That's the recommendation. But if there were some way to look at low risk people in 10 years, right? And say, well, where are they going to be in 30 years? Then you might actually be able to look at somebody in their 20s, in their 30s. And that would be much more useful because you'd be able to have kind of lifestyle intervention much sooner if you're actually able to identify those people. And finally, the multiple disease prediction. We have a big cohort for lots of other chronic diseases. And we noticed right away that the models improve when we exclude patients who have died from some other condition in the meantime, right? And of course, that makes perfect sense. But then the natural question is, can we model multiple diseases at the same time and assess which of these risks, which of these competing risks is the one that we should be most concerned about, right? So this could improve not just cardiovascular risk by accounting for these competing factors, but actually determine which outcome is we would benefit most from trying to intervene on for this particular patient. Okay, so that's all I have. I'll take questions.
Hey, David, it's Ravi.
Hey, Ravi.
So this is a kind of a blossoming topic in cardiology, even more than it was 10 years ago. The newer calculators do allow you to estimate risk for 20-year-olds now, 20 up to 79. That's the ACC Risk Estimator Plus calculator. But what will be interesting to see is now we're going to have data 20, 30 years out from when these calculators were first created. And so inputting that into the data set and into these models should allow you and all the other researchers to come up with more accurate risk prediction.
Yeah, definitely. I mean, this is, yeah, go ahead.
Great talk. Thank you.
Can wait for any questions. Otherwise, Ravi can start with his presentation. David is also part of that same team, so we'll give a couple of minutes for anyone. There's a question about sharing slides. Yes, we will be sending a package. Give us a couple of days or maybe a week. We'll be sending the recordings also, yes.
Can I ask a question?
Oh, of course.
Hi, my name is Roger Joe. I'm a doctoral student in the Department of Economics. I think this is a very interesting presentation. I just want to know that if there's any interest in knowing how or through what kind of mechanism that certain variables or features enter the decision of, or enter the probability that there might be a cardiovascular disease or any of those outcomes of interest. Wouldn't you have to build some sort of model with a more specific parametric structure so that you specify the way it enters your prediction rather than leaving it non-parametrically to the machine learning algorithm?
Yeah, so this is a big issue, right? It depends on the use case to some extent, right? If the use case is really just we want as accurate a prediction as possible, and we're less concerned with how this particular variable affects the population as a whole, then the non-parametric situation is okay, and we can tolerate a little bit of opaqueness. But as you say, if we want to say something about, well, how is this particular variable affecting our prediction, either on this particular patient or averaged across the population in general, then parametric assumptions are really useful, right? Because they give us a clear interpretation. We can read off of the parametric model. This is the role that this variable plays. There are ways to estimate the effect of a variable on a prediction. I know in Justin's presentation, he showed some of the Shapley values for predictors and how they contributed to individual predictions. So you can do things like that, but that's much more rough than having a parametric model where you actually specify the effect that you're estimating. So this is kind of a trade-off, and you have to be very conscious of it. Yeah, and as Dr. Honavar said, when you have the parametric model, you need your parametric assumptions to be correct, right? And that's always a risk. So if you have good reason to make good parametric assumptions, and your use case is that you want to be able to look at the effects of particular parameters, then yeah, it's very useful to go that route.
I'm just a little concerned that sometimes machine learning algorithm can throw out variables just by coincidence or by reasons we don't really understand. And in the end, for example, the Lasso just picks out the variables that they're there in your list, right? But we don't really know why it is that the Lasso picks these variables.
Yeah, absolutely. Like when you have correlated variables, a machine learning model can take one of them and use it to make the prediction, but it's not necessarily the variable that is causing the effect that you see. And so whenever you look at a predictive model, you need to be very careful with distinguishing between information that allows you to make a prediction and factors that are literally affecting the outcome, right? We'll talk about things like effect size, but even there, what we really mean is effect on the prediction. We don't mean causal effect unless we explicitly build a causal model. So yeah, there's people can be a little gung-ho about machine learning models and think that, well, if this information predicts that, then I've solved the mechanism, but not so, right? There's a difference.
Thank you.